we talk about personality disorders, very often we think just about emotion stable personality disorder or borderline personality disorder. But the reality is there are lots of other personality disorders that you need to be aware of. Why is this important? It's important because there are evidence-based treatments for personality disorders. Okay, so despite what people may tell you that actually nothing can be done for these patients, etc., it's absolutely not true. And I think often what happens is they get very stigmatized and can feel very much like mental health services in particular can let them down and feel that nothing is done for them. Okay, and I guess one of the reasons for that is sometimes it's not as overt, it's not as obvious as the patient who's got schizophrenia, who's become floridly psychotic and clearly relapsed. Okay. So I'm going to take you through a little bit about epidemiology and etiology of personality disorders. And again, it's just more to provide a brief overview. But then I want to focus a little bit on different clusters of personality disorder and actually the common features of each. Again, very easy exam questions to ask and to be written really is kind of knowing about the different personality disorder types. And I'm going to spend a little bit of time focusing on emotion stable personality disorder or what you may know as borderline personality disorder. And those of you that have ever set foot on a general adult inpatient ward, particular female ward, will have come across lots of these patients, or those of you that have spent time in A&E will come across lots of these particular patients at times of crisis. We're talking about a very complex diagnosis and really quite a common diagnosis as well. We think in the region of 5% of the UK population. And I'll touch a little bit on management options and also then in terms of outcome prognosis, because I think it's particularly important to stress these things, because often people with personality disorder feel less sort of satisfied as, what does the future hold? Am I ever going to be any better? And the reality, quite simply, is that personality disorders tend to burn out, if you like, with age. So the older people get, the less troubled they are by the specific traits or deficits within personality that attract that diagnosis then of personality disorder. So what do we mean by this diagnosis? Well, I think the first and most important thing to say is there's no real clear agreement about definition of personality disorder. I think if we were doing this face to face, one of the questions I would like to ask students is, what does the term personality disorder mean to you? Or how would you define that term? Or if a patient says to you, I've been told I've got a personality disorder, what does that actually mean? Okay. I think first and foremost, what I would say is that the idea behind personality disorder is this is something that starts very early on in life. Okay. So when you look back and I suppose, what we've got to do, and this is where it's really important that you take a good developmental history, is actually look at, when do these problems first start? And often what you find is it's from birth, it's from early childhood. So forming those attachments or difficulties forming those attachments with primary caregivers, mum and dad. Yeah, so we often talk about stable and unstable attachments. And people with emotion stable personality disorder will very typically and very commonly have that kind of unstable or disorganized attachment. So it starts very early on in life. And the other really important thing is that it's pervasive. Okay, so it's seen for a number of years. Okay, so this isn't something that suddenly appears when you're 25 that you've never had prior to the age of 25, but that then continues to trouble you. Okay, so in personality disorder, we clearly see a longitudinal course to the difficulties that may present. And I think it's important to recognize that actually it's not only individuals that suffer as a result of being given this particular diagnosis, but actually there's a significant burden on the healthcare system, on social care, and certainly criminal justice as well. So if you were to walk into HMP Liverpool or Walton Jail today, what you would find is at least 3/4 of the inmates there would satisfy the criteria for having antisocial or dissocial personality disorder. So lots of people who end up in court, who end up in prison, have those dissocial or antisocial personality traits. And I come across these on the general adult inpatient ward as well. So it's not just in prisons, it's not just in forensic inpatient units. We see them in general adult inpatient units as well, sadly. But then think about the frequency with which these patients present to A&E, or the frequency with which they present to the GP. Often can be quite draining on healthcare resources. So actually, it's in our national interest that actually we have an interest in this particular diagnosis within mental health, and actually look at what are the evidence-based treatments for it, and how can we reduce that level of burden, that level of cost associated with the diagnosis. So if you were asking for a definition, I think this is probably about the best one really that I could think of. So it describes innate and enduring characteristics of an individual which shape attitudes, thoughts, and behaviours in response to situations. And that's what we mean in a nutshell by personality. And it's when these enduring characteristics cause the individual distress or difficulties, that's when they're said to have a personality disorder. Now, there's an interesting school of thought about this term personality disorder, and that is that it's actually really a very stigmatizing label. And then actually it doesn't really help us in psychiatry, and certainly doesn't endear us to our patients that are given this diagnosis. And if you look at ICD-11, which is coming out in the next couple of years, which is our diagnostic Bible, as I mentioned earlier, what that really focuses on is personality difficulties rather than personality disorder. And I think, I tend to stay away from using the term disorder following personality with disorder, because I think when you mention personality disorder to patients, it often has quite negative connotations and has quite a stigma, and patients don't typically respond to that particularly well. Okay, and the important thing to remember as well, of course, particularly those of you interested in CAMS, working in child and adolescent mental health, is that personality is continuing to develop and to mature right through teenage years. Okay, and certainly the clinical psychologist I work with at Clockview Hospital very much believes that no one should be being diagnosed with a personality disorder before the age of 18, because one's personality is still in the process of developing and can still be shaped. So often what you may see in patients who are in their teenage years is this idea of emerging emotion state of personality disorder, or something to that effect. But certainly you shouldn't be making that diagnosis of personality disorder in anyone under the age of 18. So just something to be mindful and wary of. So it's considered separate to mental illness, but the two interact. And I think it's really important to remember that there's very few individuals who have a diagnosis of personality disorder but don't have a comorbid mental disorder. And often we talk about this idea of severe and enduring mental illness, or SMI, and straight away we think of recurrent depressive disorder, we think of bipolar disorder, schizophrenia. They're severe and enduring mental illnesses. Personality disorder is what we call a mental disorder. So within the meaning of ICD-10, it's a mental disorder, and as such, may warrant someone needing to be assessed under the Mental Health Act. But ICD-10 defines it as enduring, persistent, and pervasive disorders of inner experience and behaviour that cause distress or significant impairment in social functioning. So you've got a couple of definitions there for what we mean by personality disorder. And certainly I would commend you to sort of have an idea about how we define personality disorder, because I think it could be something that's quite difficult to vocalize or to put in written form, but actually is a really important concept to remember, particularly if you're seeing someone who has been given that particular diagnosis. And it's important to remember it's not just one single cognitive domain that may be affected by personality disorder. So it may well affect memory, it may well affect mood states, behaviours, emotions, and how they're regulated, etc. And I think the other important thing to recognise as well is that the presentation must not be due to other mental disorders. Okay, so what you'd need to do is exclude any other mental disorder, such as a psychotic episode or a manic episode, before you make that diagnosis of personality disorder. And again, it should be out of keeping with social and cultural norms. So you need to sort of bear in mind the need for context there. Okay, so I wanted to put this slide in because, I think even in the mental health sphere, there's a lot of controversy over this label of personality disorder. And I think these patients are really incredibly interesting because, they're often very stigmatized, not only within mental health care settings, but in other healthcare settings as well. And I've seen this, I've witnessed this And you know, I've kind of really been quite horrified by some of what I've seen. But you know, there is some school of thought within psychiatry that actually there is no treatment of people with personality disorders, and these are some of the things that people come up with, and I think really they're you know, they're what I would call myths, if you like. So personality is by definition unchangeable. Well, that's completely not true, because the whole evidence base behind personality disorder treatment really is psychological therapy, which helps people to change their behaviors, which helps people to develop coping skills, etc. So that's just complete nonsense, really. No evidence that people with mental health services help people with personality disorder. Again, you know, there's absolutely no, you know, there's no truth to that at all, because I've seen patients with both who've received both pharmacological treatment and psychological treatment who've clearly been helped. Unfortunately, these patients can have quite a detrimental impact on other patients, and I have seen that on the ward, and it's particularly the case when you have several patients with emotion state personality disorder all on the same ward at the same time, and that can become really quite toxic, and patients can start to learn behaviour from each other, and that can be particularly problematic in patients with comorbid mild learning disability. You know, who perhaps were never used to ligature or never used to swallow foreign bodies, but then start to do that when they see other patients do that on the ward, because they see that as a way of eliciting care from staff. Okay, these patients not mentally are not responsible for their behaviour. Well, you know, again, you know, there's a lot of controversy now about whether these patients have capacity for their actions at the time of them, if they're in a state of acute crisis. And this is, you know, an ongoing discussion that ourselves within psychiatry are having with social care colleagues in relation to, you know, people with emotion state personality disorder, the self-harm or that ligature. You know, are they actually responsible for their behaviour at such times? And yeah, it's not just a social problem. Often social problems exacerbate the underlying personality difficulties, but essentially, you know, there is a lot that mental health services can do. So what are the counter arguments then in terms of why would you say actually, you know, this does fall within the remit? Why is this part of our bread and butter? So people with personality disorder suffer from symptoms related to the disorder, and that is absolutely true. And you know, I think it's something that's very evident when patients come into hospital when they're in a state of crisis, and these patients are incredibly risky. And I always like to quote the figure of 9% of patients with emotion state personality disorder will commit suicide at some point. So it's important to recognise that you are dealing with an incredibly risky cohort of patients, okay? And they have high rates of comorbidity with other mental disorders, okay? And there is an evidence base behind psychological treatment approaches for these patients. So particularly emotion stable personality disorder, there is a large evidence base for using specific specialised forms of psychological therapy called dialectical behaviour therapy, or DBT, and also mentalisation-based treatment, MBT. So there are effective treatments, and that is demonstrated in the literature. Okay, and it's something that I try to stress to patients with personality disorder in terms of trying to offer them that hope that actually we can do something to make them better and less likely to become revolving door patients. Their opponents are rejecting them because they dislike them. I think this is very true, and actually you see an awful lot of negative feelings evoked within mental health care staff, not only psychiatrists but also nursing staff, you know, about these patients, particularly when they're on the ward, when they're difficult to discharge. They're often not particularly well liked, and they're very good at splitting staff. So you have to be very careful that actually these patients don't cause underlying tensions and splitting within the team. And I think this last point is really probably one of the most important points that I would really hammer home, is that there isn't enough available for these patients. You know, it's amazing the prevalence of personality disorder, and yet the lack of evidence-based and appropriate services for them. So we're very fortunate in Merseycare that we have a specialist personality disorder service called the PD Hub. But if you go, for example, into Cheshire Wirral, a neighbouring trust in Chester Wirral, or if you go to Northwest Boroughs up in Warrington, St Helens, Wiston, they don't have a specialist personality disorder service. So it can be very dependent in terms of where you are. And I think we're very fortunate in Liverpool to have that specialist service that's available to these complex patients. So how do we classify personality disorders? Well, you can classify them into two groups depending on etiology. So we can talk about this first group of acquired versus organic. So acquired personality disorders clearly develop following some sort of insult. So an example of this would be the patient who is assaulted, who's hit over the head, who suffers a frontal lobe injury and subsequently becomes very sexually disinhibited, very impulsive, unable to plan, and kind of has what we call dysexecutive syndrome. So that would be an example of an acquired personality disorder. So that personality change has not been from a very early age, it's been following a specific insult. Okay. But if that particular insult is some sort of brain damage or disease, so for example, following a stroke or brain tumor, and very often we see this with post-stroke patients, you get almost complete personality change, and it can be really quite disturbing for a patient's spouse or family. That's what we call organic personality disorder. Okay. So that's the first group, and that's how we may subdivide it. And then this second group, what we call specific personality disorders, and that's what I've been talking about thus far. This onset in adolescence, sometimes even at childhood, or perhaps sometimes early adulthood. And it can be difficult to find a direct causal relationship between those personality traits and any one specific insult. But often, if you look back at the developmental history, there's indicators that might actually point to, where those personality difficulties originated from, where they first started to become noticed. And then we talk about the three clusters, and I always think the easy way to remember these is mad, bad, and sad. Okay, so cluster A, mad, cluster B, bad, and cluster C, sad. It's a very crude way of remembering them, but sometimes, it's quite an easy way to allow you to remember them. But if you are sort of thinking about cluster personality disorder, these are essentially how we cluster them. So in cluster A, we've got paranoid, schizoid, and schizotypal disorder, and I'm going to tell you a little bit about clinical features of each, just very briefly. Cluster B, then emotion stable, which I most commonly see. Dissocial personality disorder, which is what you'll see if you work in prisons or in forensic hospitals. Narcissistic personality disorder, I think a lot of doctors are narcissistic, and we see that quite a lot with some of our patients as well. Histrionic personality disorder. And then we've got cluster C, and these are the ones that you're much less likely to see in the inpatient setting, but very likely to see in the primary care setting, or perhaps in the community mental health setting. So dependent personality disorder, the anxious or avoidant personality disorder, and then the obsessive compulsive or anancastic personality disorder. I think the important thing to remember here is that lots of patients may well have traits of more than one of those. So, it's often all too easy to pigeonhole a patient into one personality disorder label, but actually they may well have some paranoid personality traits and some dissocial personality traits, and certainly lots of doctors would have some anancastic personality traits, and that's what makes them really competent and high achieving doctors. So what do we mean by paranoid personality disorder? These are patients typically suspected of harming or deceiving them, or they may doubt a spouse's fidelity. Okay, so they're absolutely convinced that their wife or their husband is cheating on them. They very often bear grudges and very litigious and have a tenacious sense of personal rights. And I think these are patients that I very rarely see on the ward. I think I've only seen a couple of patients with a diagnosis of paranoid personality disorder, but the patients that typically don't respond particularly well to antipsychotic medication. So you think by giving them antipsychotic medication, you'll reduce the levels of paranoia, but actually you don't actually tend to make an awful lot of difference in terms of lessening the severity or the intensity of those symptoms. Schizoid personality disorder is something that could very easily be confused for autistic spectrum disorder or autism. So this idea of emotional coldness, neither enjoying or desiring close or personal or sexual relationships, preferring solitary activities, that sort of person who's very much a loner, who's quite happy with their own company, takes pleasure in few activities, who perhaps, very sort of intense interest in one or two interests or hobbies, and who are very indifferent to praise or criticism. So again, easy to see how you might sort of think, well, is this schizoid personality disorder, or is this someone who's on the autistic spectrum? Okay. And what about schizotypal? Well, very often people believe this is a prodrome to schizophrenia. And lots of these patients will go on to subsequently attract a diagnosis of schizophrenia. And you can see why, because the clinical features there are very typical with what you may well see in the patient who's given a diagnosis of schizophrenia. And it's important to remember you don't always get those positive symptoms like perceptual disturbances, like the odd beliefs and magical thinking that may well take on a delusional slant. You may also get those deficits, those things like social withdrawal. So don't forget, in the patient with psychosis, very often within the prodrome, that social withdrawal is kind of a key feature in terms of making that diagnosis. So what about emotion state personality disorder? I mean, I guess really as a general adult inpatient consultant, I see an awful lot of these patients, and I would say out of my 19 patients I have on the ward at the moment, I probably have certainly two or three patients with this diagnosis at any one time, and I have quite recently had as many as 6 or 7. So I see an awful lot of emotion state personality disorder on the ward, and I think really these are patients that you can't get away from, and they need to be able to manage in the correct way. And what I've done here is kind of listed some of the common features that you would expect to find, and it's important to recognize that with emotion state personality disorder, the Americans call it borderline personality disorder. Here in the UK, we don't call it borderline personality disorder as such, according to ICD-10. We call it emotion stable because effectively there are 2 types. So you have the emotion stable impulsive type and emotion stable borderline type. And patients may well have a mixture of the impulsive traits and the borderline traits. So for example, unstable self-image is an example of one of the borderline traits associated with emotion stable personality disorder as per ICD-10. Very often with these patients, they can be really quite risky because of their impulsivity. And, you know, that may take several forms. And lots of these patients will engage in alcohol misuse and or illicit substance use and engage in quite risky behaviors. Very often eating disorder is, you know, a comorbid diagnosis. And I see a lot of patients with emotion state personality disorder who have a comorbid diagnosis of bulimia nervosa or anorexia nervosa. And it's easy to kind of understand why that may be the case, because with these patients, they feel very much not in control of things going on in their lives. So they feel very much like everything's outside of their control. Whereas in terms of their eating habits, very much something they can firmly control themselves, because they can deliberately restrict, they can deliberately purge. So they very much achieve that sense of control that they really crave, that they don't see in other spheres. Repetitive suicidal self-harm behaviour. Well, this tends to be why patients with emotion state personality disorder come to the ward, often with this suicidality. And the reality is the suicidality is chronic. The reality is it's often very stable, but at times of crisis, it may well escalate. And the risk to self may become significantly elevated. And these patients will often talk about having psychosis or having schizophrenia, and that's because they talk about hearing voices. And I think really, if you learn nothing else today, what I would want you to take on board is that hearing voices does not always mean someone is psychotic or that someone has got schizophrenia. So hearing voices can be a perfectly normal phenomenon. And if you talk to psychologists about hearing voices, they talk a lot about normalizing those experiences and actually learning to cope with voice hearing and learning to live with it. And patients with emotion state personality disorder very often report voice hearing, but the nature of the voice hearing is different to that in psychosis. So in psychosis, in sort of true auditory hallucinations, those voice hearing experiences are in external subjective space, okay? So they recognize the voices as sounding like someone talking into their ear, or sounding like someone in the next room talking to them, or someone stood behind them talking to them. Whereas the patient with emotion stable personality disorder who reports voice hearing will talk about internal voices, so voices inside their head, and they're what we call pseudo hallucinations. Okay, and very often the content is really quite derogatory, so calling that individual fat, or telling them they're worthless, they're useless, and command in nature, telling them to harm themselves or telling them to kill themselves, sometimes telling them to harm others. Okay, so those voice hearing experiences are what we call pseudo hallucinations, and patients with emotion state personality disorder at times of crisis or at times of distress. So, for example, if you know, they are kicked out of their accommodation, they may well go into sort of an acutely decompensated state and become really quite paranoid. And, you know, everyone's talking about me, everyone's looking at me. But when you explore that a little bit more, they can't really tell you why it's them in particular and why it's everyone. It's just a general feeling that they have, but it can be really quite damaging and result in sort of significant isolation as a result. But these patients have not necessarily become psychotic. They're what we call quasi-psychotic symptoms or transient psychotic symptoms. Okay, and you commonly find with patients with emotional personality disorder are these dissociative states, okay, or episodes of dissociation, and that's effectively the brain's way of shutting down in situations of extreme stress. So if they experience some form of trauma, by dissociating, that individual is able to sort of cope with that particular trauma. And often then what you find is these patients have very little recollection of what just went on, and they can become extremely violent towards themselves or towards other people or towards property. But when you ask them subsequently, they have very little recollection or memory of what just happened. So that's what we call dissociation. So, you know, lots of these patients will dissociate, and that can happen in a variety of settings, not just one particular setting. So what about dissocial personality disorder? Well, you know, these are the liars, those that are really deceitful, and those that are aggressive and break the law. And of course, it's never their fault. It's never them that are responsible. You know, I smacked the guy in the pub because he shouldn't have smiled at me the way he did. So it's this idea of lack of remorse, lack of guilt. And very often when you take a personal history from these patients, what you'll find is that in at least 50% of them, they'll have this diagnosis called conduct disorder in childhood. And certainly those of you that have done CAMS, you may well have come across adolescents with this diagnosis of conduct disorder. I guess to the layperson, they may call it naughty child syndrome, but lots of these patients will have conduct disorder in adolescence, early involvements with the criminal justice system, so early age at time of first arrest, regularly being suspended from school, expelled from school, often ending up in behavioural units, you know, poor educational performance, and getting into sort of lots of fights, etc. Narcissistic personality disorder. Well, you know, I think there's probably a little bit of this in a lot of doctors, and you know, I'm not going to single out specialties as such, but I think there are certainly a lot of doctors that are very narcissistic, and I guess to a large extent, it can be really quite advantageous and beneficial. But obviously, when it becomes, you know, so overwhelming, it becomes diagnosed as a disorder as such, it's perhaps not quite something to be proud of. So what about histrionic personality disorder? Well, I've got a 7-year-old who's almost 8, who's very much histrionic at the moment, but he's very much kind of what we call attention seeking or dramatic, exaggerated expressions of emotion, very much like to be the center of attention. Okay. And then what about cluster C? So these are the patients I don't tend to see an awful lot of, which is just as well really, because I think the inpatient setting would be really quite a scary and intimidating place for them. So dependent patients, these tend to rely very much on other people to make important decisions, and they tend to be very, I guess what you may call needy. Okay, and an anxious personality disorder, don't forget these, you would differentiate from the patient with an anxious disorder, because in the anxious disorder, usually it's a discrete episode, or there's a clear time when the problems first started, whereas an anxious personality, those anxious traits have been present from a very early age, and they'll have often been present in primary school, secondary school, and they very often we talk about sort of fears of inadequacy or feeling inhibited in certain social situations, and tend to be very sort of sensitive to criticism. And then finally, anancastic. So, you know, I sort of look at this, and I see a lot of myself in this probably, but I do think it's what makes doctors good doctors to a large extent. Perhaps when it becomes pathological, it's not such a good thing. But, you know, the reality is you don't see a lot of patients given this diagnosis of anancastic or obsessive compulsive personality disorder. But I think certainly lots of us would have some of those traits, and I'm sure at least some of you recognise yourselves within that particular diagnosis. So what about etiology? Well, a bit like any mental disorder that we've spoken about today, there is this clear interaction between environment and biological or genetic factors. And this is seen certainly if you look at monozygotic and dizygotic twins, okay, so identical, non-identical twins. So in identical twins, you get higher concordance for personality disorders. So there's clearly a genetic factor at play there. And you know, I mentioned earlier about sort of schizotype of personality disorder often going on to be diagnosed with having schizophrenia. Well, it's certainly more common in relatives of patients with schizophrenia. Okay, and then I spoke a bit about schizoid perhaps being confused with autistic spectrum disorder. So again, you can see there's overlap there. Patients with emotion state personality very often have anxiety and depression as comorbidities, and often some PTSD as well. And actually what you tend to find in cluster B personality disorders, so emotion stable, dissocial, histrionic, etc., is that you'll get early adverse social circumstances. So it's really important to really go right back to the beginning as much as possible. And I guess one of the ways that you can do that and get a really decent developmental history is to speak to that person's mother or father or someone who knows that person really well, because obviously our own recollection of how we were as a baby or as a toddler is going to be very sketchy or non-existent. But clearly mum or dad will be able to tell you, oh, he was a really difficult baby, he was very clingy. You know, he always used to cry if I put him down or tried to leave him with someone, okay, in perhaps the dependent personality disorder patient. And very often there is this link with childhood sexual abuse and emotion state personality disorder. But lots of patients will say, well, I can't have emotion state personality disorder because I don't have any history of sexual abuse. We think it's between 50 and 75% of patients who have a diagnosis of emotion state personality disorder that actually have a history of childhood sexual abuse. So although it's commonly found, it's certainly not, it's certainly not if it's not there, then they don't have that diagnosis, but you do commonly find that in the background. And it's certainly something that if it's present in the personal history should make you think about, does this person perhaps have some emotion stable traits or perhaps the full personality disorder? And I've spoken already a little bit about attachment and this idea of how infants attached to caregivers, primary and secondary caregivers, how that can then lead to difficulties in relationships later on in life. So, for example, if you have someone with a rather disorganized or insecure attachment in childhood, that person may well in later life find it very difficult to form lasting friendships. They may well be quite fearful of doing so because they fear being abandoned or rejected by that particular friendship, or they may well struggle to trust people in relationships. Or what you then tend to find is those relationships become really quite volatile and quite fiery. And what about epidemiology? Well, why is it important we recognize these? Well, it's clearly because the mortality is increased, okay, and both physical and psychiatric morbidity is increased as well. So it's incredibly important that we're able to pick up personality disorder as a diagnosis and don't just dismiss it. And one of the hardest things is trying to estimate prevalence because no one's really that clear. And I think, again, this highlights the degree of diagnostic uncertainty within psychiatry, particularly, and probably, no more so than with personality disorder as a diagnosis. Anything between 4 and 13%. Certainly in terms of prevalence, it's much more likely to be diagnosed in younger age groups. And I mentioned before that you wouldn't ordinarily diagnose someone with a personality disorder before the age of 18. But certainly, if you go and work in older adult psychiatry or old age psychiatry, you're not going to come across many patients who've got a primary diagnosis of some form of personality disorder. You will see 1 or 2 of them. I have seen 1 or 2 of them, but as with most personality disorders, emotion state personality disorder tends to burn out with age, and that's for example, if you look at the prison population, you won't find many prisoners who are older than the age of 65 or 70. And again, it's important because these patients will turn up at your GP surgery, they will turn up in your psychiatric outpatient clinic, you will find them on the wards, you will find them in prison. So you can't get away from patients with this diagnosis. So how should you assess them? Well, often, the reality is that these patients are in states of crisis or distress at times when they come into contact with mental health services. So I guess that in itself makes it difficult to form that therapeutic alliance and to be able to do that assessment in any meaningful way. What you have to really look for are things like any evidence of comorbid mental illness or mental disorder, what's causing the distress to that particular individual or others, and how can you identify and pinpoint those sources of distress, and what are the impairments in terms of sort of social functioning or occupational functioning, or relationships at home, so perhaps relationships with spouse or with other family members. And I guess really with personality disorder, one of the most important things is taking a good developmental and personal history. And I think that's going to be best achieved by speaking with preferably mum or dad, and getting some collateral history to really try to unpick and understand when did these difficulties first start. And actually invariably what you find with patients with personality disorder is that these difficulties start at a very early age. So I've said already, try and obtain collateral information where possible. And that will help you to understand and differentiate between transient or short-lived patterns of behaviour and those that are more enduring, or what we call pervasive. Okay, and I've spoken a little bit about transference and countertransference, and I think one of the things that I would encourage you all to do is to sort of make sure you know what these terms mean, because I think it's really important that you're very self-aware when you're interacting with all patients in medicine, not just those with mental health difficulties, and certainly not just those with personality-based difficulties, but this idea that these patients really can evoke strong emotional reactions within you, and that can very much be projected then onto the patient. So if you're not careful, what you find is you find yourself mirroring the patient. So the patient is becoming angry at you and becoming very critical towards you. So you then start to raise your voice and you're critical back to the patient. And that may then lead to a complete breakdown in relationship and no real therapeutic alliance. So you've got to be aware of your own emotions, and you've got to be non-judgmental and empathetic in your approach. And that's really, really difficult sometimes. And I find that difficult as a consultant of 4 years experience. So I think certainly as a trainee doctor, as a medical student, it's incredibly difficult. And it's okay to experience those emotions and those sort of preconceived ideas. It's how you then manage them. Okay, so long as you can identify them and regulate them and not let them impair how you interact with that particular patient. Now, there are questionnaires available to diagnose personality disorder, and probably the most commonly used one is something called the IPDE, which is an incredibly long questionnaire that consists of almost 600 items to diagnose someone with personality disorder. In reality, certainly in the general adult setting, we don't really use diagnostic instruments for diagnosing personality disorder. It tends to be more in sort of research spheres or in forensic settings, but it's certainly something to be aware of. So how do we manage personality disorder patients? Well, as I've said, they often present at times of crisis. And I think really what you have to do is just be individualistic in terms of your approach, really, because what works for one patient is not necessarily going to work for the other. So there is this real need to work collaboratively with the patient and, to jointly agree on goals. And it's important that these goals are realistic goals, okay? And it's important that they're explicit. So one of the things about particularly patients with emotion state personality disorder is they don't deal with uncertainty too well. So it's very, you've got to be very black and white, and you have to be consistent in your approach. And that's not only you as an individual medical practitioner, but also nursing staff, psychologists, other members of the team, whether that's in the inpatient or outpatient setting. If you don't have that consistency of approach, these patients can be very difficult to manage in the right way. And I've just listed some of the potential management goals there that you would be thinking about. And I guess, it's kind of having a basic understanding of them is important, but I wouldn't expect you to sort of know that in any great detail for the purpose of undergraduate exams. Admission to hospital, often something that we have to be very careful about. We often think of hospital being beneficial, only doing patients good, but actually it does a lot of patients with personality disorder bad, and it can make them a hell of a lot worse. And I've seen this, and I've had patients with the diagnosis of personality disorder who've had really quite prolonged, protracted, unnecessarily long admissions, and they got an awful lot worse before they got better. So prolonged hospital admission is not helpful, and that can often be a source of tension between doctor and patient with a personality disorder. But it's certainly something that you have to buy into as an inpatient consultant, because actually you're doing that person no favours whatsoever by keeping them in hospital. So whilst you feel that you're containing the risk to self, actually what you're doing is actually increasing the long-term risk to self. Okay. That said, admission to hospital may be required at times of crisis, or it may be required if there's evidence of comorbid mental disorder that needs treatment. Okay, but what we should be aiming for
is treatment in the community, okay? And really, I mean, there are these things called therapeutic communities, of which there are several in the UK. I think the local one to Liverpool is in York, actually, so it's not that close at all. It's about 100 miles north. But there are therapeutic communities, and there is certainly an evidence base in emotion state personality disorder for use of them. But these patients will often go into crisis from very simple life events. So it might be something as simple as mum has gone away on holiday and left them at home alone, or their care coordinator has gone on leave, and that person then feels abandoned, they feel lost, so they then go into crisis mode. And what about prognosis? Well, you know, is it a lifelong condition and a poor prognosis? Well, it is a lifelong condition, but there is no doubt that as I mentioned earlier, that the traits do lessen and diminish with increasing age. They do tend to burn out. You know, and I think that will be seen if you look across the sort of general adult wards and the older adult wards. You know, you go into the older adult wards, very few patients with personality disorder. And it's interesting that almost up to half of patients with emotion state personality disorder don't meet the diagnostic criteria if you follow them up for 20 years. But lots of them will continue to have that emotion state personality disorder diagnosis. Okay. And certain personality disorder subtypes have poorer prognosis. So, for example, schizotypal, because we know that lots of these patients will go on to develop schizophrenia. And we know that patients with obsessive compulsive or anacastic personality disorder, they may worsen with age and they're more likely to become depressed, for example, than those with obsessive compulsive disorder. So in a nutshell, or in summary, what the evidence suggests is that cluster A personality traits tend to worsen with age, cluster B improve, and cluster C to remain relatively stable and unchanged. So I just want to finish off quickly by talking about emotionally unstable personality disorder. And really I want to focus on this because this is the personality disorder subtype you're going to see most of within the sort of healthcare setting. And that's regardless of whether you're talking about the mental health setting or A&E setting or within general practice or whichever medical or surgical specialty you go into. So these are the diagnostic criteria. And I spoke before about there being impulsive type and borderline type. And I don't think really from a management point of view, it's too important whether you specify the particular subtype. I think the important thing is offering evidence-based treatments. But these are the typical features that you would expect. And often patients with emotion state personality disorder have a very poor understanding of the diagnosis. So I'm always horrified when these patients tell me that, you know, they've been given this diagnosis or this diagnostic label, but no one's ever really told them what it means. And very often it leads to a real sort of negative outlook or a real sort of negative attitude towards being given that label. And actually what can be very helpful is some basic psychoeducation, and that might be something as simple as showing them the ICD-10 criteria for emotion state personality disorder. And actually they're able to tell you, well, I've got that and that. Oh, now I understand what this means. And that could be really quite validating for the patient. So it's an important thing to think about. And I think it's important to remember that patients don't have to have all of these clinical features to have the diagnosis of personality disorder. They may just have to have some of them. And I said before that with emotion state personality disorder, it's incredibly common. And actually, again, a bit like with any other personality disorder, it's really quite difficult to be quite accurate and confident in terms of what's the prevalence within the UK. And we think it's anywhere up to almost 6%. But we know, one of the things that we know for certain is it's more commonly diagnosed in females than males. And I guess really I would sort of ask you to think about why that might be the case. So it's something like 3 times more common in females than males. And perhaps if I tell you that dissocial personality disorder is about 3 times more commonly diagnosed in males rather than females, that might help you to understand the gender difference. And actually what it's down to is that females tend to internalize feelings of anger and that males are much more likely to externalize feelings of anger. So they're much more likely to be aggressive towards others, whereas females are more aggressive, are more likely to internalize that aggression in the form of self-harm or ligaturing or suicidality. Now, obviously that's a gross generalization, and I'm not suggesting for a minute that that applies across the board, but it helps you to understand a little bit perhaps why there's that differential gender diagnosis between emotion state personality disorder and dissocial personality disorder. But most of these patients will have early contact with mental health services. Very often it's with CAMS actually, and lots of my patients with emotion state personality disorder have been under CAMS, have done psychological therapy, and have then transitioned into adult services. And this lifetime suicide rate of 9%, that's something that never sits particularly easy with any psychiatrist, nor should it. But the reality is that it's very unlikely that if you manage these patients on a regular basis, the way I do, that they won't commit suicide. And there were certainly a handful of patients that I've assessed over the years as a psychiatrist with emotion state personality disorder that have gone on to commit suicide, whether that's intentional or accidental, because there is a high risk of accidental suicide or death by misadventure. And what about etiology specific to emotion state personality? Well, there is a clear etiological link with childhood sexual abuse. Very often that's a sort of family member, whether it's sort of uncle or dad or granddad, or maybe a neighbor or male cousin. And very often that can impact, subsequently with how that individual interacts with, healthcare practitioners. So lots of my patients with emotion state personality disorder really struggle to form any sort of therapeutic alliance with me because I'm male. So me being a male doctor straight away puts me on the back foot with these patients. And often it could be helpful, even if you have a sort of female SHO or SPR, to ask that particular person to take a lead in any interaction, because it can be, it can just allow that patient to open up a little bit more easily, because they can have a real distrust of males, a real dislike of males, and that becomes very much generalized because of previous adverse experience with a particular male. And very often, if you look at their developmental history, what you'll see is that these patients don't tend to be able to hold down jobs. So their employment history tends to be either non-existent or pretty scatty, and they are often sort of suspended from periods of employment, or maybe sacked because of poor timekeeping, etc., or drug use. So very often their employment history is quite poor. That's not to say that they can't hold down employment, but just that it might be more difficult for them. And as I mentioned earlier, obviously with relationships can be very difficult for these patients. And often what you'll find is that they really struggle to maintain lasting relationships. They don't tend to get married and have sort of relationships lasting years, or get married and stay with their partner for significant periods of time. I've mentioned earlier about comorbidity, and it's particularly, I would say, depression and anxiety, eating disorders and illicit substance use. But I think I would add another mental disorder diagnosis to that, as well as PTSD. So lots of these patients will present with PTSD features, and that's really related to the specific previous trauma, whether that's childhood sexual abuse, or whether it's physical abuse in childhood, the alcoholic father that was always physically violent towards mum, and that the child witnessed on a daily basis, that almost kind of normalization of violent behavior. That can cause significant PTSD. So you get those flashbacks, those nightmares, that irritability that we associate as being characteristic of PTSD. So what about management of these patients? Well, I think first and foremost, it's really important to say that we should not be excluding these patients. We should not be stigmatizing them and discriminating against them just purely because of the diagnosis. And similarly, that's not just within healthcare services, but also social care as well. And lots of these patients will have unmet social care needs. They will really struggle to live independently in the community, and they really do benefit from having that input and support from social care. So we shouldn't be excluding them. But it's important to be consistent and tolerant. And I think that's particularly difficult for some doctors. And for other doctors, it's perhaps a little bit easier. But how should you be? Well, optimistic, trusting, and non-judgmental, okay? And that is the ideal, really, in terms of trying to form that sort of therapeutic alliance. And that can be really, really helpful and beneficial, particularly when you're looking at being able to try to discharge this patient in crisis. And we often talk about endings and transitions as evoking strong emotions and reactions within these patients. So it's important that you prepare the patient for these endings or transitions. So for example, if they're undergoing psychological therapy and it's long-term therapy and you're coming towards the end, it's important that you prepare them for that ending. Or if they're being moved from one community mental health team to another, and that's a significant transition in terms of their community psychiatric care, it's important you prepare them for that so it's not just sprung on them. And you should treat any comorbidities. If you identify them, then you need to treat them appropriately. Okay, so what about crisis management? Well, these tend to be when I see these patients in the inpatient setting. And really, we should think about crisis management planning, and that needs to be done collaboratively. Okay, and that needs to be done with the patient, not for the patient, because I always think that if it's done with the patient, then it helps that patient have ownership of their crisis plan, and they can shape that crisis plan. So they can tell you, actually, when I'm really struggling, it does help me to be in hospital, or it really does help me to have 3 days or 5 days of some regular diazepam. So it can be useful to use benzodiazepines on a short-term basis, but only during a crisis, okay? And you should be careful about dispensing large amounts of these medications, because lots of these patients are a high risk to self in terms of risk of overdose. So what you don't want to be doing is giving them a month's worth of diazepam that they can then go and overdose on. So very often they'll be subject to once weekly scripts of their prescriptions. And you may want to try the crisis resolution and home treatment team before considering admission. But the reality is lots of these patients invariably say they don't like being under the crisis team. And the main reason for that is that they see a different practitioner every day. So you don't get that consistent approach that these patients really crave and certainly they require and benefit from. Hospital admission may well be necessary, and it may well be life-saving for these patients. No one's naive enough, myself included, to think that we should just never admit these patients to hospital, because clearly there are times when it is indicated, and there are times when you have to contain the risk by bringing the person in. Very often that may well be, subject to detention under the Mental Health Act. Obviously, we try to manage them informally on the ward as a less restrictive option. But what is absolutely paramount is that you sit down with the patient and agree, what are the goals of the admission? What should be the length? Why are they coming into hospital? Are they coming into hospital because their accommodation is broken down? Are they coming into hospital, for any other specific reason? So you need to agree that at the start, really. And obviously, if a patient goes into crisis, then you should be revisiting that crisis plan when that crisis is subsequently resolved. And that should regularly be done so that it remains valid and it remains appropriate and relevant for that particular patient. And we often talk about this thing called an extended care plan. And this is something that we use in Liverpool and Mersey Care for patients with emotion state personality disorder. And it's those patients that regularly go into crisis. And the idea behind it is that you involve the patient, you involve the patient's community team, so their community consultant, their care coordinator, and you involve the patient's family as well. And that's collaboratively produced then as an extended. So what about short-term and long-term management? Well, short-term management in terms of psychopharmacology can be quite simply summarized as there is no licensed psychotropic medication in emotion state personality disorder. So it's very commonly used within this diagnosis, but actually it's being used off license. So it's important that that's stressed to patients. Some patients swear that antipsychotics help reduce the voice hearing experiences. We know, for example, that clopixol, which is one of the older generation, one of the first generation antipsychotics, helps to reduce aggression and impulsivity. Mood stabilizers sometimes can be helpful in reducing mood instability and impulsivity, but they're not being licensed for that particular use. So what's much more important is psychosocial intervention, okay? So having that regular contact with a particular healthcare professional, psychoeducation around the condition, addressing any social issues. So I've got a young lady on the ward at the moment at Clopview Hospital who's got a diagnosis of emotion state personality disorder, who very much self-medicates through engaging in harmful use of alcohol, who's purely come into hospital because she's not happy with her flat and where she's living and is waiting to go into supported living placement. And actually what she's done is sold a lot of her possessions within the flat for alcohol. So she's kind of living in squalor really, and is currently on an acute care ward really with no medical issues that need addressing. She's purely what I would call a social admission. But clearly we have to address that social issue before we can think about discharging that particular patient. And longer term, well, don't forget that it can take a heck of a long time to really address these personality traits. and to try and modify them. But it's not the case that you can't modify these personality traits. You absolutely can. One of the biggest barriers to success in terms of treatment, unfortunately, is high attrition rates. Lots of patients will disengage with psychotherapy. And there are lots of reasons for that. And one of them is that psychotherapy is often very protracted. We're talking many months rather than several sessions or several weeks. So, for example, if you go into DBT, it lasts anything between 12 and 18 months. So, lots of patients can't manage that length of therapy. Lots of these patients will drink and use drugs and consequently become really quite chaotic. So again, they drop out of therapy. But in terms of the psychotherapy that's got a good evidence base, and certainly what I would expect you to know for the exams will be, the fact that DBT and MBT are the two gold standard psychotherapeutic interventions in emotion state of personality disorder. There may well also be a role for CBT and cognitive analytic therapy, and also psychodynamic psychotherapy as well. But certainly they're not the gold standard treatments the way that MBT and DBT are. And I mentioned before about therapeutic communities, but the reality is I've never been able to discharge any of my patients to a therapeutic community, and they're very much few and far between. There are only several of them running within the UK. Okay, so that's it for personality.